So a warm welcome to you all on this sunny Sunday. I think Sunday is the last day of the conference and most of the people leave by this time. Anyway, the war will continue. There's the war of flaps. Our first speaker is Dr. Monica Jethani. She is very renowned cataract and LASIK surgeon from Vadodara. She is the director of the Eye Clinic Vadodara LASIK Laser Center at Vasana Baipuli Road in Vadodara. She is a gold medalist and she got Best Paper Award in Gujarat Ophthalmic Society, Best Video Award in Maharashtra Ophthalmic Society. She has also conducted various state and national level conferences and she has 6 publications in the Index journal. She is a multi-talented woman and a dignified personality. And she won lots of awards. I think with the paucity of time, I'll not cover all, but she is a wonderful lady and always interested in refractive and cataract surgery. She'll be presenting today microkeratoum LASIK is still the best. Our second speaker is Dr. G.S. Dhami. He is consultant cataract and refractive surgeon at Dhami Eye Hospital, Ludhiana. He presented papers in the international conferences ASCRS, ISCRS. He has been chairman, judge, panelist at the international conferences, and he was awarded Dr. Vinod Arora Oration at the annual conference of Uttarakhand Society of Ophthalmic Society. He is past president of IIRSI. He has several publications to Indian and international forum. He was first to start phacoemulsification and refractive surgery in Punjab. A great credit to Dr. Dhami. He'll be speaking on femtosecond safer LASIK. Then we have Dr. Anand Parstati. He'll be just joining us. He is chief surgeon of the Center for Vision and Eye Surgery at Chennai. He did his fellowship in refractive surgery, cataract and cornea at the University of Erlangen under Professor Klaus Korsian from Germany. And he did fellowship from Singapore National Eye Institute under Professor Donaldson. Again under Dr. Nagarao from LVP at Hyderabad. He won the Best Poster Award at the American Academy of Ophthalmology at 2007. He has won the C.P. Gupta Award at TNOA, E.T. Salvam Award at the Postgraduate Award in 2001. He has published more than 35 papers. He is invited faculty at ASCRS, ISCRS, APO, WOC, SOA, AIOS, DOS, and BO and other conferences also. Dr. Anand Parthasarthi will cover Smile All the Way. And we have with us the star speaker, Dr. Rohit Shetty. He needs no introduction. He is the consultant cornea and refractive surgeon. He vice chairman at Narayan Netralaya, Bangalore. His special interest is in clinical and translation scientists and grow laboratories. He is a faculty in the Department of Ophthalmology at Maastricht University. He has keen interest in keratoconus and corneal ectatic disorder. He is the chief mentor of dual academic program of PhD and clinical fellowship at Narayan Netralaya Institute, Bangalore and Maastricht University. He has more than 350 publications in peer-reviewed journals. He has won Colonel Rangacharya Award in AIOS 2015. He has won Achievement Award from AAO, and he has won again the Case-Spear Awards. A lot of research. I think Narayan Netralaya has become one of the symbol of top Indian ophthalmology of the research and authenticity. Professor Rohit Shetty will be speaking on Wavelight Plus for the eyes. And it's me, not much, but I'm at Dehradun and past president of IIRSI, NJOS and UKSOS. I'm presently member managing committee AIOS, published over 30 papers, sub-editor of Himalayan Journal of Ophthalmology. I'm reviewer of IGO, then won the Best Paper Award in DOS in 2000, presented over 7,000 papers, keynote addresses, conducted courses, national and international conferences, awarded IIRSI Gold Medal at Chennai, awarded IGO Honor Award in 2020. I presented Dr. B.P. Kashyap Oration Award at Jharkhand and awarded ASCRS Fellow Excellence Award Outstanding Contribution for the surgery. So with this, we start. I think Dr. Rohit has to attend other session also. So I'll invite him first. Dr. Rohit, please.
Good morning, and sir, thank you for this wonderful opportunity, and also my co-panelists in this, Dr. Monica and Dami sir. We've learned so many things from each other over the last many years. Today, the topic given is the Wavelight Plus, which is something which is trending in refractive surgery for your eyes. No financial interest linked to this. Been using this technology for the last close to a year now, and now it's introduced officially, but we have been using it for different other research activities. If you look at the Alcon's journey, it started with wavefront optimized. It's more of preserving the corneal asphericity than wavefront guided, the topo guided, and also in between there is FCAT and the QCAT and all these factors which Dr. Dami has shown very beautifully about its potential. And some of it I feel could have taken to the next level if Alcon had understood or listened to Dr. Dami's work on this, and then probably they could have brought this up much earlier than what it is today. So when you look at the standard treatment, it's basically based on your manifest refraction, the wavefront treatments based on the ocular wavefront, and it has its own customization. The Contura has a mix of what it can do on your corneal topographies. But when you're looking at the fully personalized one, you're looking at the complete optical system of the eye, which starts with your cornea, the anterior chamber depth. It's like the formulas of today compared to what IOL formulas of many years back, when you had you had a model eye, which is and most of your formulas was based on that. So if you look at these two factors which I already mentioned, it is most of it with the values what you're getting of how your ablation is. It's like etching a lens, a glass power onto your cornea, and it uses the standard one for all theory, use the Gullstrand model, and we know it does have its own challenges and limitations, and all laser profiles are based on this. So when you look at ray tracing, which is a completely new dimensions, it's not based on one model of the eye. You remove the model of the eye completely out. Based on Snell's law, where you use multiple rays of light and how it forms on the retina, it uses every aspect of it: the anterior cornea, the posterior cornea, the lens, the thickness of the lens, and things like what you would actually use in your IOL calculation, because that's why your IOL formulas and calculations have become so important today, and all optical elements have been measured. So how does it help to customize? It looks at a complete topography, both anterior and posterior. It uses your biometry, and so for that we need to have machines which works on it, which looks at both. So that's where you look at the Innovice, where you have the Pentacam, which has an abrometer, and the Scheinflug imaging, which is your traditional topographer, and the laser interferometry. And then you get all these values out there, which is fed into a digital model. We call it the virtual digital model. And of course, now everything has AI built in it, and you create a front surface ablation because based on your entire model of the eye. So this is how Innovice works. Innovice is nothing but a Pentacam, and this is the screenshot of a Pentacam out there. You need to take at least 4 wavefront scans, so it takes a little longer time. It's not like one scan. You have to take multiple scans. You have to have a proper size of the pupil. If your pupil size is too big, it doesn't give you, it asks you to go back. So you have to dim the light, put a cloth sometimes. And you have to at least have 2 wavefront maps which match with the subjective refraction. And in the past we were looking at 6 measurements. Now we have come down on this, and then it takes all the other parameters. What's interesting here is it is supposedly helps to even factor in your epithelial remodeling. There are senior surgeons like Dr. Vinod sir and Dr. Dami here. if you really look at your earlier generation refractive surgeries, one of the major cause of regression for you was how the epithelium was remodeling, the change. So a 10, 15 microns of epithelium would and make your patient go back to change of asphericity or change in your corneal, corneal spherical equivalent. So what we did was we looked at, compared a contura with this one, which even now it's one of my favorite procedures. And what is interesting here is not much of a difference in the gross quantity of vision, but the gain of line is definitely more. And this is something which is early data. You have more gain of lines than any other procedures I compared with. Smile, Sil, Contura, Wavefront Optimize. So one of the things is that it is giving you an extra gain of lines. It's not making you better than Contura in getting 20/20 vision, but it's definitely giving you much higher gain of lines, which we do today. So why do we still need customized laser? Yesterday there was a debate and they said, will Silk, Smile, AIOS will take the customization off? It will never take the customization off, because at this point of time, I don't foresee in the near future also, the lasers are the only one can create that customization what we see with the best of procedures. For example, if you look at this person with the 3.5 diopters refraction, the cornea looks okay. Look at the epithelial maps out here. The epithelial is irregular. So when you look at the MS39, the MS39 actually gives you the epithelial cylinder. There is an epithelial cylinder coming from close to around 0.5, 0.75 of epithelial cylinders. Even though the patient is not accepting any cylinder here, maybe he's balanced by the lens, but he's still having an epithelium which is quite irregular. An irregular epithelium induces cylinder, which is very important. But you also have changes in your posterior corneas. But what this machine does is, it factoring in all these components of cylinders, and it's giving you that this is what you would probably need to correct, rather than just doing a non-cylindrical correction. So that means that you're factoring in the multiple things. Even in a zero ablation, you can see that there is a lot of correction it does, more of trefoil, which is probably coming from an epithelium or the stromal level. So it is true customization, and this is a map which I'm quite impressed with the new technology called AIOS. AIOS is a company which makes refractive lasers. They use pure, they're more of a PRK based machines. It was there in the booth here. And they have an abrometer called Precisio, which gives you a ray tracing refractive map of your epithelium, which is very exciting way of looking at it, because that this ray tracing of Precisio takes care of the ablation from the epithelium. And this is a ray tracing. This is not a thickness map. This is a ray tracing refractive map. And when you do a ablation profile, when you're not bothered about your epithelial irregularity, do a ray tracing, you do a customized one, your epithelium will grow in any way you want. But when you create a beautiful shape, your post-ops will be more regular in shape. This is a ray tracing dioptric gradient change which happens. So that means that there is definitely some role of creating a more gradient change on your epithelium. And there's a few epithelial maps. The blues are the ones where your refractive changes a 1.4 diopter ray tracing refraction on an epithelium compared to the surroundings. So you can see that there is so much of change which is happening, which can be corrected. So what is the patient feedback? They report sharper vision. We did not tell them we have done a new procedure, otherwise his brain gets biased. And there is definitely a more better level of the quality of vision. The quality is one, and the gain of line, which is the first time we are seeing that level of gain, which we can push the limits of gains. So higher visual accuracy, because using a total ray tracing, you're using a pupil recognition, you're using the pentacam data. Aberrations, I don't see it's heavily reduced, but it's still, I feel, is better than what I've been seeing. And it is definitely a one step above if you're adopting to a newer technologies. And even though I'm a Silk Smile surgeon, the quality of vision day one is, I don't think any of these machines can really match to the level what we are getting here. Thank you, and thank you, Vinod sir, for this opportunity.
Thank you, sir. Thank you for such a wonderful presentation. Just one or two questions, sir. Do you think totally aberration-free is a perfect model for the eye? Because some of the aberrations may be helpful.
So when we did not have proper understanding from a time when Monica was there, Dr. Dami and all of us were part of the Alcon meets, we used to harp about zero aberration concepts. Yeah. Then we realized the zero aberration doesn't happen, because even if you create zero, your lens is going to be taking over from there, and one or the other culprits will be there. So what Innovice is trying to do is, it is factoring in the epithelial remodeling, and I think both of you as seniors would agree that challenges is how the epithelial remodels. You do a silk or smile, one of them, and you create a beautiful system. After 1 year, you see a ray tracing map here with 1 diopters of thing, you are finished. And I mean, for both of you, anybody wants to visit our lab and work on this, is a fantastic optical thing, especially Dami sir, when you are looking at your Q changes and how an epithelial remodeling will change your Q, or even Dan Reinstein's work. It's a fantastic one. And the second thing is, sir, your collagen, when you have a laser which you burn, if your collagen is strong, it has a different way in which it behaves. If collagen is weak, the collagen fibers after you heal gets remodeled in a different way. So whatever SA, coma you wanted to correct gets nullified, because your healing becomes completely different. And that is where I think ray tracing takes into an account of every layer and gives you a much organized map.
Right. And if you compare with the topographic guided one,
quantity is the same, but the gain of line is more.
Okay.
And this is consistent even with the other two published work on it.
And the aberrations are already on the cornea. Whatever we were learning, that in wavefront guided, there is hardly 4% of the patient who had got RMS more than 2.5. So is there any...
So what happens is, when you're doing a topo-guided contura, you're correcting the cornea beautifully, then the lens is not factored in. When you're doing this procedure, it takes into the accommodation change. It also looks into the how much of the lens is giving you an how you balancing the aberration. So AI will then decide how much of aberration I should actually correct both from the cornea and the lens, so that I can balance it, so that I don't create an imbalance between them. The whole challenge with contura, why we were not getting more gains, is that you create a good corneal aberration-free zone, but your lens aberrations is not balanced. In ray tracing, because it's a forward ray tracing, you look at everything. It also knows how much is the lens compensating and how much is lens adding. So you get a complete one compared to a non-complete one. For example, if Dr. Jatlani wants to tomorrow do a LASIK on an amblyopic eye, this would be the way to go, because an amblyopic eye has a huge amount of lens which is going to compensate for him. He treats the power of -6, but the lens is still compensating. The whole amblyopia in a child gets completely nullified. So if you do this, you are completely looked at the entire optical system, so he can look at how much of lens is actually playing. So it's a huge leap in the way we look at refractive modeling.
Very good talk. Always is a pleasure to hear you, Dr. Shetty. But my question is, we have one culprit, that is the epithelium. I have seen it. It's the only culprit in refractive surgery, which probably with all this we have come to prove it. But in one of your talks, you were mentioning as immunomodulators to be given.
For all of them.
For all of them. What and when to start these?
Sir, I have a scoring system, simple one. Of course, I will not talk about my biomarkers because it's not come to the clinic yet. The patient is contact lens intolerant, and the patient has a meibomian gland drop more than 25%. The patient has a high OSDI. The patient has a T-but of less than 5. And patient has nociceptive symptoms, like he complains that I can't see the light, I can't face the AC and all that. you know this person has already high threshold of inflammation. These patients, I start them 2 weeks prior, these immunomodulators. I can choose between cyclosporin or lifitegrast. Lifitegrast works faster so that I can reduce it to 1 week. And then I keep them out for 3 months and along with the drops. But if these patients don't have any of the symptoms pre-op and they're quite okay, then you don't need to bother about it because epithelial remodeling is usually well. If a patient is a contact lens intolerant, there is a 96 to 97% chance he will remodel post-surgery very badly. Where I think ray tracing helps is it has already factored in the component of how the shape is, and it will also have an AI which will tell you this is the shape of the cornea which is going to be, and this is how the epithelium will re-go in that area. So the laser spots are given in such a way that the components of healing gets more nicely balanced compared to a non-ray tracing procedure.
Rohit sir, a small question. I mean, it's regarding Trehalose. I had heard in a NN meeting only that it causes epithelial remodeling.
It causes not remodeling, it causes epithelial swelling in the first few weeks. The epithelial swelling goes because it contains sugar. Any sugar has a little tendency, so it does not create a change enough to be bothered, but after long term doesn't change much.
So my question is, should we use it in post-LASIK patients or not?
It's a remodeling by the way that it doesn't allow the unregulated growth of epithelium. So
Okay.
that means it doesn't allow it to heap up epithelium, and when you do a LASIK or one of them, it has factors to improve the nerve growth.
So we can use.
Yeah, that is my drug of choice for all post-op patients.
Okay.
Now, once we have got a regression and we have proved that it is epithelial hyperplasia or irregular epithelial, what do you advise at that stage?
PRK sir, topo-guided PRK.
Any immunomodulators first?
You give a immunomodulators for 2 to 3 weeks, but when you use mitomycin, irrespective of how much you burn, I keep the mitomycin amount double, means the time double, because epithelial remodeling is driven by TNF alpha driven pathways. So even if you treat a 0.25, you'll get a very bad haze. So epithelial remodeling cases have to be re-looked at it completely differently.
Will tell us how much is the refractive error by the epithelium?
No sir, not now.
Or regression? No.
Only your MS39 will tell you.
Okay.
So you will have to combine both the technologies.
Thank you.
I'll go back to one session and come back after
Sir,
that.
thank you so much. It's always a learning. Thank you. And our next speaker is Dr. Monica Jethani. She is going to speak on microkeratome. LASIK is still the best. Dr. Monica, please.
Good morning, everyone. I would like to thank Dr. Vinod Arora for including me in this wonderful instruction course. So, why are we discussing about microkeratome in 2025 at All India Conference? Let's look at some of the pointers for the same. So there are variety of microkeratomes available in the market, and the whole purpose of putting this slide is that it has reached a stage where no more developments are taking place. If you see in years after SBK and ML7, we have not come across a newer microkeratome. Reason being, it is a quite well-developed technology by now. There were different types of microkeratomes available, and now we have come to a conclusion which one is the best for us. To look at it, initially the lenticules which were made by the rotatory microkeratomes, which were available with Bausch & Lomb machine, Z100, and I have been fortunate enough to use almost all the microkeratomes and almost all the LASIK machines possible. So now the microkeratomes which are available make a quite linear and planar flaps, which was possible only with Femto. and this is a comparative list between the different kind of microkeratomes available. Initially, when my father started, they were making flaps of around 140 microns, but now with the microkeratome also, I mean, it has been years that we can make a flap of 90 micron, which is the minimal. And we have microkeratomes like ML7, where you can just change the blade and you can alter the thickness of the flap, like -10, +10, all that things are available. We all have heard this saying that old is gold, and so is true with microkeratomes. We have to understand and analyze, and I think one of the most important factors for putting this presentation into AIOS 2025 is we stay in India, and value for money is also very important. If we come on this stage, it is only 1% of ophthalmologists who are speaking about these machines, and as listeners, we take home back that if we do not have Contura, or we do not have Silk, or we do not have Smile, then we are lagging behind somewhere. I don't think that's true, and we have to understand, and as speakers, we have to preach this, that microkeratome is also going to stay. If we take home this message, this is the extremely important slide, that we should not be reusing the blades. The most of the complications and problems which arise due to microkeratomes is because of the reuse of the blade, because it's in the hand of doctors. There are people who use it for single patient, and there are people who use it for the whole session they have on that day. So that ethical practice we need to follow. So this we have already discussed, that 90 micron is possible. So in conferences, we hear people speaking about buttonholes and free and incomplete flap. But if you look at the reality check, what is the incidence? I mean, in 13, 14 years of my career of LASIK, I have never had a buttonhole. So why are we still talking about buttonholes with microkeratomes? Just because we want to promote a newer technology, we want to bring that machine into the market, we degrade what was already available. So now we have comparable flaps with femto, and the post-op wow effect, I would say, when I had used femto, it is much better with LASIK than with femto, because of, I mean, on the next post-op day, and then both of them become equal. So limitation of Smile is that still work on hyperopia is going on, and on lasers, where we think to minimize the thickness of the stroma, I mean the thickness of the cornea, which we use for correcting the refractive error. In case of Smile, when it is a very small diopters like 0.5, 0.75, we have to do a flat head. So we have to understand that Smile is still a developing technology, and now something like Silk has come into the market. They would change something from planar to biconvex, and they want to launch 6.5 crore machine into the market, and we as ophthalmologists are compelled. So in institutional practices, it is possible, but in general practice, we have to understand that it is not that important, and we cannot go ahead with refractive surgeries with microkeratomes. Also, even if you see in animations, they would not show the manual separation. They'll just show an incision made and lenticule comes out, which is not the reality. You have to separate the lenticule manually. You can easily see that lenticule is being separated manually in Smile. Opaque bubble layer, I know now is not a problem, but still why I have included this slide is that if we position the spots, two spots very close, then there'll be opaque bubble layer. So now we cannot position the two spots very close, and that is why manual separation you have to do. It has got a little steep learning curve, and if we discuss about pros and cons of LASIK, LASIK has been a very predictable procedure, very quick recovery, high diopters can be treated. It can also correct hyperopia, and thinner flaps are possible. Cons are two-step, problems with flap may occur, and chances of free flap folds and stria. But after having said that, if your technique is beautiful, if you take care of the vacuum part, if you take care of repositing the flap properly, I have not come across any micro or macro stria in so many years. So coming to the conclusion, take-home message is old is gold. It's cost-effective. Reuse of blade should absolutely be avoided. Manual separation is needed in smile or silk. No buttonholes, 90 micron is possible. Nasal flap is possible, in which we can preserve maximum number of nerves and its value for money. And to conclude, I would like to say that pre-operative workup is the key. We are talking about Contura correcting 4 microns, 7 microns, which is the thickness of the tear film. So what are we correcting? And I'm not at all against the technology. We always adapt the technology, and the show must go on. And you have to understand that you are important and not the machine. Be so knowledgeable, you master your own machine and not let the machine master you. Thank you so much.
Thank you so much. I think the microchrome has evolved a lot from what we were getting
Yes,
much
sir.
earlier. Now we can get a planar flap just like Femto. We can get a oval flap. So I think it's quite comparable and much economical, easy to learn. Of course, every procedure had some complication.
Yes,
Nothing
sir.
is, no surgery is without complication.
Yes,
So
sir.
every machine has its own set of complications. You can't say it's with this one or it's with this one. So we have to learn them and be prepared for that. Thank you so much,
Thank
Dr.
you, sir.
Monica.
Thank you.
And our next speaker is,
Hello, there's a small question.
Yes.
please.
Like they say that in microkeratomes,
Yes.
there can be a tendency for a free flap.
Yes, sir.
So what key readings you take pre-op as a safeguard? You don't go less than that for free flap or even buttonholing for that matter.
Sir, honestly, I have operated at 40 also. The only thing is that you have to be very, very cautious with the ring size what you are
Yeah,
selecting.
yeah, exactly.
Usually what has been seen is only the most common ring size are used until and unless, the K readings are very steep or very flat. What we follow in our setup is we change rings even for 2 eyes of a one patient.
exactly,
So that's very important, and the most important factor is proper achievement of vacuum.
Yeah.
If you check your vacuum, flap complications would become a history.
Yeah, exactly. And then I like to add, sir, one more thing, that so many doctors, they have this femtosecond laser, but they're not using it. They're still using microkeratomes. I mean, I don't know, this is something out of the way, but there's so many doctors, they want to sell their femtosecond lasers, and they tell us that we've hardly used it because we have been using all the time microkeratomes.
No, I don't agree with that one. Most of us are using both the things. It depends on the patient and whatever the patient is willing.
Yeah.
Of course, Femto has a consumables,
Yeah.
so it's more costly.
Yeah.
But otherwise, I think it's a fantastic machine.
Yeah.
It gives a very good and predictable results.
And what about the glare? I mean, because we are using too much laser with femtosecond lasers. Is there any glare difference between the two?
No, there's no glare. Only thing the pain is little more. If you talk about the post-op pain, maybe in microchrome patient may be comfortable within 2-3 hours.
Yeah, yeah.
But the femtolasic, it may be around 5 to 6 hours.
Otherwise,
That's all.
no difference in glare.
No difference in the glare results or any other things like that one.
Sir,
Thank you.
glare has got much, and I think we should measure all the pupil sizes.
I think,
And we should, if possible, should be correcting our, because we measure pupil size in every patient and we increase the optical treatment zone. And if it is beyond that, beyond our increase, we always inform the patient that you already have night vision problems and that's gonna stay. So, you don't complain later this post-surgery.
Yeah.
And second, in the older machine, there was a decentered ablation sometime. That caused also the glare. But that's not common with the modern machines. So I think femto is a perfect thing, microkeratome is a perfect thing, smile is a perfect thing, and even the advanced surface ablation is a perfect thing. So all are working. That's why all are working.
Yeah. Okay, thank you, sir.
So our next speaker is Dr. G.S. Dhami. He is going to speak on femtosecond, a safer LASIK.
Thank you, Vinod. It's a pleasure always being among you and to show our experience and what we really think when we talk about refractive surgery. I have one line underlined in my OPD and my OT. I should know what I don't know. I think the whole story ends, all complications come to minimum when you know what you don't know. So you know you have not to do it, then why do you try that step at a particular reading or what? Let's begin with this. Now, the only question asked to me was always, will Klex replace excimer laser? I have only few points before I come down to my topic, but I believe the excimer has to stay and will stay. Let's talk about 4 limitations of Klex. No ray treatments possible. Fine treatments like topo-guided, others you just heard, Dr. Roy Shetty, are not possible. Wavefront guided, not possible. Learning curve with Klex is larger, longer, and still complication added. Now, when you don't want to do smile, Monica said rightly, economical limits are very big. Opacities in the cornea, you know you can't do it, don't try it. If an already procedure has been done, you cannot do. Pure cylinders, limits of power. Then what do we have? For advanced ablations, we have bladeless LASIK, wavefront optimized, wavefront guided, and topography guided, are to be done either with blade or with intralace. That's what is my topic. Features of femtosecond LASIK flap. In brief, it has a pocket, which is about 220 to 250 microns deep. A hinge, which can be made anywhere. It gives you a very good exposure. Flap diameter can be manipulated for a myopic, for a cylinder, for a high prop. Flap thickness, which is the most important factor to look after your PTA, that is percentage of tissue ablation, is only possible with intralace. Side cut, whether you want to have 90 or 120, is only possible with intralace. So that's the advantages. And what is really it is? Femtosecond lasers are designed to deliver a biomechanically engineered flap, a faster procedure, exceptional flap lift, advanced customization of the flaps, and is contemporary ergonomic design to the cornea. Mechanism, I think, need not to explain. Principle is of photodisruption. Laser energy is absorbed by the tissue, which results in plasma formation. Expansion of plasma creates cavitation bubbles, which separate the tissue plane. That's how the tissue is separated to whatever thickness, whatever plane, whatever way you want. Advantages: reduced incidence of flap complications. Believe me, it do happen. They happen. You have to know when they will not happen. That's exactly with microkeratome, same with intralace. Predictability is very good. Surgeon's control is excellent. That's why it dominates the microkeratome. Because of flap width, depth of thickness, diameter, side cut angles, and hinge. Suction loss is there, but you know that you can control it, whereas in microkeratome you cannot. That's the one drawback. But when you know it, you will never have it. Other applications, they can be with microkeratome also, penetrating keratoplasty, intacts, and clicks. And of course, if aberrant flaps are created, no damage is done, you can repeat it at a different depth. Drawbacks, everything has a drawback, whether you fly a jet or a rocket or a car, maybe 700 or Mercedes. Higher keratocyte activation leads to what we were just talking, higher incidence of DLK. Definitely because of when the energy is uncontrolled, DLK is more. So why should it happen? You should know it. Optimize your energy levels. Complications specific to femtosecond laser, opaque bubble layer, vertical gas breakthrough, air bubbles in the anterior chamber. Transient light sensitivity, we'll talk about these more. Rainbow glare, we were just discussing, we'll talk more. The consensus is then, femtosecond laser is the preferred option for flap creation. Of course, the cost is more due to reproducibility, safety, precision, and versatility. Why? Because we were cutting elliptical flaps. They give us a larger area to treat. Any flap, any size flap can be created. It can be customized. That's the most important thing. The bevel cut and the inverted cut in the flap. That makes your flap stable. Virtually, lifting is effortless and a stronger adhesion is there. Biomechanical strength is affected by the side cut only. That's the big difference between a microkeratome and the intralace. We need not to repeat. The inverted bevel cut brings it to the topmost. Higher repetition rate, tighter spot separation, low energy, lower incidence of OBL, and OBLs are soft. They will go away immediately. Of course, everything is under control on your digital microscope. It matches the anatomical elliptical shape of the cornea. That is a big difference. It prevents resection of vital peripheral corneal nerves that aids in dry eye, moves the hinge to periphery for a maximum stromal bed. You can have a superior hinge, you can have a nasal hinge. Allows use of wider hinge angle for greater flaps. And virtually you can treat whatever side and whatever cylinder you want, whether it's a nasal hinge or a superior hinge. I think I can overtake this slide. How to minimize complication, that I said, you ought to know what I can prevent. A good docking procedure, treatment energy, patient counseling, and patient laser handling. Believe me, patient counseling is most important because most of the patients, our patients, at least on area, understand it's a laser procedure. I will go in and I will come out, which is not. Patient treatment planning, training of the surgeon, proper sterilization is must. Docking involves topical anesthesia, it's a learning curve. Tell the patient, small eyes are a problem, but if you have not counseled the patient, you might land up in problems. And flap lift is good. It may not be as good as in the blade, but it's definitely perfect. Once you are experienced, you can lift it, but not like a flap lift in microkeratome. Well, complications are bound to be there. Improper setting and calibration, most important. You have paid for the CMC, keep calling the engineer. Don't tell him that the machine is okay. Improper device handling by the surgeon, very important. Wrong or precise use of surgical instruments. Uncooperative patient counseling is very important. And of course, inadequate atmospheric conditions in the room, temperature and humidity. Intraoperative complications are great, many, yet it is good. Decentered flaps, suction loss, uncut areas, flap tearing, anterior chamber bubble, and vertical gas breakthrough. Let's see if we can show you some. That's the suction loss. The only good thing is that you can repeat the procedure immediately. You got it, and you can repeat it. Opaque bubble layer, yes, it causes to change your style of practice. You have to make a flap, ask the patient wait, and then lift. And the cause is only high energy, and mild OBL can be cleared with the help of slight massage, but for dense, you got to wait and let the patient wait in the OPD. This has to be explained to the patient as step 1 and step 2. Anterior chamber bubbles need to be cautious. They trouble you at times. The cause is decentered flaps, big flap diameters, or a small cornea, and of course, improper placement of the canal. Once you have it, you can postpone it or wait till it clears up. Postoperative complications, we were talking, they are quite a bit. Rainbow glare, DLK, and epithelial ingrowth. This is mainly cause is related to the diffraction of light from the grating pattern created at the back surface of the femtosecond LASIK flap created, which you can't help. That's why I was talking to Dr. Shetty about the epithelial hyperplasia after LASIK procedures. DLK you can't avoid, you got to treat and identify it as fast as you can. Only thing is, be careful. Don't be over-enthusiastic to tell the patient you will be okay. Epithelial ingrowth is probably a fault on the part of the surgeon, which we don't commit or agree to, but it can be treated with relift of the flap and needs a different chapter to be explained. Most important is flap stria. I don't know how many of you do, but I always place a contact lens after every procedure, whether it is with intralace, whether it is blade. I was taught that by Professor Theoseller. He said, don't be miser to waste a contact lens. Thank you very much. Lastly, do believe in yourself. Smile is good. Femtosecond laser as an intralace is very good. And you can't keep away your blood. Microkeratom, I can tell you why. At times you got to make a thin flap, much thinner than what a femtosecond can give you, even on a smile procedure. Thank you very much.
Thank you so much for illustrative presentation. I think Femto has made things more predictable, and you can just know how was the size, hinge, and the side cuts, whatever you want, you can adjust, and you get the same also. But the thing is, it involves a lot of cost also. Your running cost, you have to run 2 machines, you have to put CMC, consumables, that increases. But of course, it provides additional safety. Thank you so much.
Sir, I have a personal, I want to take a suggestion from you. I have recently bought Alita. In the last 2 years, most of the flaps I made with the I am planning to sell my microkeratom. Shall I sell or the microkeratom?
You will need it. You will need it. Guide, don't sell your old instruments.
You'll get peanuts for that. And
you will get peanuts for that. And one day when you need it, you need it.
Which microkeratom do you have?
You have a
Moria. It's a good micro.
SBK?
It's a beautiful
M2,
microkeratom.
SBK. Which city are you practicing in? Okay. Sir, paying capacity of the patients, you should see who are walking in. So, I mean, if, you know, all of them can pay, then fine.
All right, it's your personal
But one day
choice.
you will have a patient who needs blade. Don't
So
sell it.
meanwhile, request Dr. Anand Parsarthi to please. Dr. Anand Parsarthi is going to speak Smile All the Way.
Can you just, Dr. Anand, smile. Just to answer that for the doctor is that it's a good way of marketing it, because there will be a set of patients who would opt for budget, there would be premium and luxury. So it actually helps to kind of diversify. Thank you, Dr. Vinod, Dr. Dhami and Monica, lovely to be part of this session again. No financial interest, but it would be good to have some. I think in terms of understanding the SMILE procedure, you have a femtosecond laser application, you have a small incision creation, you have lenticular extraction, and then of course you have natural healing. The natural healing basically is altered without the flap creation, and that is the fundamental difference in terms of SMILE versus LASIK versus PRK. There are some mild procedural differences. A SMILE is a single femtosecond laser lenticule. It's a small 2 to 4 millimeter incision. There is no flap creation, minimal nerve disruption, preserve biomechanical stability, and suitable for thin corneas and dry eyes. The LASIK requires 2 lasers, requires a large flap creation, significant nerve severing, greater biomechanical impact, restricted in thin corneas, and can exacerbate dry eyes. SMILE's flapless procedure is a significant procedural advantage which preserves the corneal integrity. Now, you look at the meta-analysis of almost about 18 comparative studies, wherein you compared SMILE, PRK and LASIK. You had an excellent visual outcome, superior or equal to LASIK, and at 6 months, 95% are 20/20 or better compared to 93% with LASIK. The long-term follow-up studies demonstrate a superior stability of SMILE versus LASIK. Mean regression is only about 0.1 diopter for SMILE compared to 0.8 diopters for LASIK. So both in terms of long-term stability, LASIK is slightly lesser than SMILE. What about astigmatism correction? Important part because you get myopic astigmatic patients. 94% for SMILE, 92% for LASIK, within about 0.5 diopters of targeted astigmatism. The mean difference between LASIK and SMILE is only about 0.1%. So astigmatism probably very, very similar. What about corneal nerve preservation? Important part, you got a faster recovery in corneal sensation with SMILE. Tear production is better preserved. You have patient comfort, you have nerve disruption, which is 60 to 70% with a LASIK and only about 10 to 15% with SMILE. This has been confirmed by corneal confocal studies which preserve that the architecture of nerve is better preserved with SMILE. And of course, the small incision also helps comfort post-operatively. When you looked at the incidence of dry eye symptoms comparing SMILE with LASIK, the SMILE nerves, because they are less cut, the incidence of dry eye is significantly lesser with SMILE. Objective dry eye measurements, when you look at tear breakup type, Schirmer's or corneal staining, the SMILE definitely scores a lot better. Now, in terms of visual quality outcomes, which is contrast sensitivity, night vision quality, and higher order aberration. So SMILE shows 12% better preservation of contrast sensitivity, better night vision quality, and 18% lower induction of spherical aberration with SMILE. This is based on multiple studies. You looked at a wavefront analysis study published in JRS and found that SMILE induced fewer high order aberrations, particularly spherical aberration and comma. An important part is about corneal hysteresis, tensile strength, and residual bed strain, and this is through corneal modeling, which is basically indicates that the strength of the cornea post smile surgery is better than LASIK. The flap versus flapless, very common point for discussion is in terms of subclinical applications, which is microstriae, interface debris, epithelial ingrowth. Minor complications like flap displacement, irregularity and dry eye, and major complications like flap amputation, buttonholes and infectious keratitis. Post LASIK ectasia, definitely a vision threatening complication, and you can occasionally get very severe striae or very occasionally a free cap. But almost about 1.8% of LASIK procedures compared to 0.3% of smile procedures have complications. I'll then come to the surgical technique. This is a patient where you have a dry surface, not ideal. What you're looking for is a perfect laser pattern during surgery, and I'll discuss the surgical technique more in detail. Docking, always adopt a soft dock approach. You got to activate suction at about 70% applanation, check for pupil centration before you go ahead. So this is the procedure. You got the in view and you got an additional camera to check the applanation, and now you got a very perfect dock. You got a cut which is very centered on the pupil, between 8 to 20 seconds depending on machine that you have. The lenticule dissection technique is basically an inner circle represents a lenticule, the outer circle represents a cap. The space between the lenticule is about 0.5 millimeters and the size of incision is about 2.5. The anterior pocket must be dissected first before proceeding to the posterior pocket. So the superior pocket opening is important because you got to begin by opening up the incision, stay within 0.25 millimeters of the cap, within about 0.25 millimeters the open incision on both sides. This ensures that there is a plane which can dissect the anterior. So this is just to demonstrate that. So you open up, this is of course done under topical anesthesia. You got to do it early before the bubbles disappear. So you use a separator, you go only in the anterior part first, and then you attempt the dissection of the second part. Your inferior opening is important because you got to avoid going in the wrong plane. So once the opening of the anterior pocket is delineated, we now move the instrument in the posterior pocket. Just make a 0.5 opening. There are something called the ridge sign where you can make out the lift of the stroma before you actually do that. So you've done the anterior, now you're going to go for the posterior part. So this, you're going under the cut and now you're lifting up. So now just to make sure on the posterior part, you'd go across the pocket to make sure both are not connected. Now you've got the anterior plane and the posterior plane. You can now switch the instrument to the dissector, complete the anterior dissection using swiping movements. So this is the curved dissector, and if you are a lamellar corneal surgeon, this works out quite easily. So you go anterior first, go to the full length of the dissection and do it in a gentle swerving motion so that you do not disrupt much of corneal fiber. And this has to be done gently. There is of course a fear that you would perforate, but usually if you do it gently, do it bit by bit, go to the edge of the dissection all the way where the dissection is done. And now you have dissected the anterior part. In the inferior dissection, you enter the posterior pocket now. You got to move as close to the border as possible. So how this is done is you use your dissector, go under the plane you've already created. You will feel a bit of resistance, and then go to the edge slowly because this is in the visual axis. So dissection over the visual axis has to be done a lot more slower. Go to the edge of the dissection. You will have a bit of resistance, and you got to push through the resistance. The edge dissection is important because once you've completed the anterior, the central, posterior, move the instrument from 1 to 5 o'clock and the edge is dissected in these clock hours first. So this is just a video to demonstrate that. You make a edge, you go beyond the edge of the posterior lamellae, you go on one side first, you leave a bit of the, now you go to the other side. Now you got about a central island which holds the lenticule in place, and you do the second part of the dissection on the left side. So you go to the edge, you can make out the edge of the lenticule is perfectly delineated. The lenticular extraction is the final step. When done correctly, the lenticule is intact and not folded over. It's now ready to be removed with a forceps. So how you do that is you clear that central island. Now you've got a free lenticule. You then use the forceps. Just ask the patient to look down a bit. That's actually a good idea. You have a curved forceps. You go under, just kind of free it. So go anterior first, go down first, then you come out. That helps to free the dissection very well. And of course, you can make sure that you got the complete lenticule, not really important. You can hydrate, some people don't. And then once you done that, you can actually just oppose the edges. So I do this, which is the flattening on the horizontal and vertical meridians, just to make sure the stroma is opposed. This is just to show the procedure. You always center it on the pupil. The 800 has some kind of a tracking wherein you can actually make it out. This is perfectly centered. Patient looking right inside the eye. You complete the dissection. Usually takes on the older machine about 20-22 seconds. On the newer machines is hardly about 8. There are of course some complications with some diseases, which is basically suction loss, black spots, wrong lamellar dissection, some folded over lenticule, torn lenticule and retained lenticule. I would not go into all of that because that would be a separate lecture itself. The causes for suction loss are inappropriate cone size, the surface is being too wet, poor cooperation and improper docking. You can get section loss even in this femtosecond procedure because the suction amount is slightly less than a microkeratome. So you have to be, you need a cooperative patient because the amount of suction which is present with this is significantly less. Sometimes if the patient is very tense or squeezes too high when you're actually doing the applanation, that can cause it. Sometimes you see these bubbles coming around, that means the eye is moving and you're not able to get good suction. So you would need to redock and then reapply. If you have a suction loss, you can still go back and either you can wait, you can go deeper. If you've already cut, you will need to at least wait for about 15 to 20 minutes. There are of course some retreatments which can be done even in this if you have the previous parameters. I would not touch upon that. Black spots are sometimes because of suboptimal energy settings and service being too dry. Long lamellar dissection easily rectifiable by finding the anterior pocket. Usually in the first 10 cases you'll be able to you'll have slightly more difficulty. After that it kind of settles down. The learning curve for SMILE is probably 8 to 10 patients, I feel 8 to 10 eyes. And sometimes the problem is always in the initial insertion. So you go posterior first and then you go anterior. A lot of times you will have a problem. So in this you can make out that if you look very carefully, the posterior lamellae ridge is actually seen, which is important sign that you are actually in the posterior part now. I would not touch upon this. It's actually more unusual. If your dissection is done properly, you will not have folded over lenticules. There are some SMILE specific complications. Usually difficult lenticle extraction is about 1.9%, and on the early learning curve, which is about 10, it's 4.3%, and experience probably about 0.8%. There are lenticle tears, which is about 0.7%. Enhancement is about 2% compared to 3.8% for LASIK. This is just the complication rate when you compare intraoperative, early, postoperative and enhancement. Vision threatening complications are also quite significantly less across all procedures, but intraoperative probably more with LASIK compared to SMILE and PRK. So in terms of patient satisfaction, if you look at multiple published studies, the satisfaction is slightly higher for SMILE compared to LASIK. The long-term follow-up, 5-year outcomes in terms of stability, both are beyond 90%. But when you look at 5-year data, there is a bit of myopic regression, slightly more with LASIK. The ectasia risk is both are less than 1%, but SMILE is significantly lesser. And the risk factors are similar for both: thin corneas, abnormal topographies, young age, and high myopia. In special populations or in active sports, it is actually probably the preferred option. Thin corneas with respect to especially preserving the biomechanical strength, and it's probably a good alternative to phakic IOLs. Military and first responder applications is something that is also a preferred option. So future directions include faster lasers. They are now looking at topography guided SMILE. Hyperopic span still in early development, may be a challenge I feel. Automated extraction, some kind of robotic assistant, which is something that is being thought about and worked on. So key takeaways: why SMILE leads modern refractive surgery. 95% patients get 20/20 or better, significantly reduced dry eye, enhanced corneal biomechanics, elimination of flap complications, and superior patient satisfaction. Thank you so much.
Thank you so much for a very, very illustrative presentation, Dr. Anand. Dr. Anand, in LASIK we see the wow factor maybe after 5 to 6 hours. How does it happen in SMILE? I think the results are pretty good. But
I think better positions, what you're saying is correct. So the recovery does take slightly longer. I think that everybody accepts. In the 4-week follow-up, when you compare SMILE and LASIK, both are very, very similar. So I think you need to warn the patient, and we have seen patients operated where they are unhappy with the initial visual recovery because of all the ads, 20-second procedure, you're going to see everything well. So I think we have to undersell the visual recovery, but oversell the safety.
No, I differ here. Dr. Anand, we were just discussing, I told you we'll discuss it later. The visual recovery with the SMILE Pro, that is a faster laser, is 6.5 very next day. I am yet to see a patient which is not 6.6 very next day.
Interesting.
Still a wrong refractive error has been felt.
Very nice. So
That's why the wow factor of SMILE Pro is much faster.
And you think it's because of a faster laser?
It is faster laser. Because
So the faster laser helps in easier dissection, and that helps in buttercup.
Yes.
I think the machines are improving.
Yeah.
Yeah, please.
So, I mean, as of now, you know that there's no customization in lenticle procedures. So don't you think that that is a bit of a drawback?
For astigmatism or you mean in terms of power, sir?
No, not in terms of power, but in terms of topography, and now that even
Topo guided or
I think I mentioned that, so they're working on topographic guided SMILE.
as of now, what do you feel that?
See, if you have, in my opinion, so there is a subset of patients who will always do well with a wavefront guided treatment. These are patients with slightly irregular corneas, who are borderline frost, who have varying amounts of refraction. You can do SMILE extra if you are confident, but I take these patients up for a topography guided laser. I have a fairly good keratoconus practice, so I have good experience of these wavefront guided treatments, for topography guided treatments for these specific set of patients who do not fit into the normal range. So if you look at what is the normal range, I think 90 to 95% would fit into the normal range where SMILE will work well. There is a subset of 5 to 10% where you need to take a call. If the refraction for these patients 6x6, SMILE would be a better option. Sometimes a lot of these patients are 6-9 parts, they have slight irregularity, astigmatism not the linear one, they may have slight asymmetrical bow tie. Those may be a good option to consider topo-guided PRK or a trans PRK, which work equally well in terms of the final visual outcome.
If we go by the studies done by Don Reinstein, it's a very long study about correcting wavefront or optimized. SMILE lenticle, the way it is made, does not need optimization or topo-guided treatment. That's what, it's a long study, it's a 14 years follow-up, but with thousands of cases with Dan Reinstein. I have followed him quite a lot everywhere. though contradictory many times because he speaks for the company.
But lenticule is, there is no customization when we remove a
Well,
lenticule.
lenticle is made in such a way that is in the curvature. Now, the difference between the smile, the Zeiss setups, I have no financial interest, please,
Yes, sir.
and the other setups. Other setups, like microkeratome, compress the cornea, make it flat, like silk or other two lasers, and then create a flap with creating OBLs and etc. Whereas in the Zeiss platform, it goes with the curvature. Your application to the cornea, the contact is like the corneal curvature. That's why it doesn't change the whole show. Whereas other, like the J&J's machine, again no financial interest, they created a what you called as a convex type lenticule to counteract that. So probably it is the way the lenticle is made in smile that doesn't need wavefront treatments.
Add to what Dr. Dhami is saying, when you look at spherical aberration alone, so these are virgin corneas. I talked about the slightly abnormal corneas, which are borderline keratoconus, irregular astigmatism. What sir is saying is that in case you have a standard with a spherical aberration less than 0.02, which is basically the range that most Indian patients are between 0.02 to about 0.3 spherical aberration. In those set of patients, the induced the spherical aberration because of the LASIK versus because of the smile is significantly lesser. It's about 20% lesser if you looked at published studies. So in a normal range, there is no requirement because the aberration induced by creating the lenticule is significantly less.
Study some 12, 13 years back when these customizations had just started. And what we concluded was it was needed for a very small number of patients. And ultimately what we realized what we were correcting and what we were inducing, I mean, because we recorded, this abrasion was there before the surgery and this was there after the surgery. So, to my knowledge, it is needed by very few percentage of individuals. Though we promoted, that's a different thing altogether.
Exactly.
And with microkeratome also, I mean, with due respect to all other technologies, patients are reading 6.3, 6.4.
Yeah.
So, I mean, I don't know what extra I can offer them.
Yeah, you're right that
So
way.
refraction
Practically-
is the key. You give more importance to refraction
Exactly.
and a beautiful surgery. Your patients are gonna do well.
Yeah, exactly. Now, what my question was that we obviously as of now we can give a very good result with microkeratome, right? But the future lies in customization. So if the lenticle people can customize, then it's better. But we cannot say that we don't need customization because customization is also improving by the day.
This question, I think 4-5 years back, sir would not remember, in SSTC or in the stalls. I went there and I asked because I had a debate on the same. So they said Dr. Dhami sir will answer, and sir had given the same answer at that point of time also, and I clearly remember. And maybe, see, the person who has the machine, who is into the research, will be able to answer much better as sir did.
One point, Dr. Rohit Shetty, if you heard his lecture when he started, he started with this point only. When the wavelight lasers came to us, I was the first one to start customized laser. Means you are maintaining the asphericity of the cornea as it was pre. Their custom Q is the whole stuff.
All right, we
The
can
company did not promote, but then your answer is you have to shut up.
Okay, thank you.
Dr. Vinod needs no introduction to my friends from Punjab. He was one of the most popular refractive surgeons of my region. People will hire taxis and cars to reach Dehradun to get their refractive surgery done. This is what I know of Dr. Vinod, and what you know about him is written. And he is a perfect organizer, a scientific thought, brought many new additions to the conferences. 2 minutes to win. See, 2 minutes video and you win a prize. That means you took hours to create those 2 minutes. This is the creativity of Dr. Vinod Arora. Rest, I don't want to explain because you already know. Dr. Arora, please, the dais is with you.
Thank you so much for your kind introduction. And coming to the refractive surgery, I think the things keep on coming back and back. So it started with RK. If we're talking about the corneal refractive surgery, it started with RK, then PRK, then LASIK, then LASIK, intralaser, epilasic, SMILE, Contura Vision, advanced surface ablation, Wavelight Plus, all the things are coming. And the beauty are that they are staying there. So we'll just have a fair essay of these things. PRK initially was more accurate compared to RK. It was able to correct myopia, hypermetropia, astigmatism. The results were pretty stable. But initially there was a broad beam lasers. We have a lot of pain in these patients. There was a delayed healing. There was a scarring. Then came the LASIK. There was a wow factor. There was a rapid recovery. There was decreased risk of scarring. There was practically no pain in these patients. But some of the flap-related complications, of course, not common, but still they are. Like flap striae, buttonholing, partial flap, debris, epithelial ingrowth, DLK, late trauma, and the most dreaded one is the ectasia. It may occur in very minuscule of cases. Then came the femto. It was a thinner flap, fewer incomplete flaps or buttonholing, flap-related complications were practically gone, but some problem with the femto still persisted, like Dr. Dhami has told you, photophobia, rainbow effect, higher DLK, late trauma, and can displose the flap, and ectasia may be there. Then came the SMILE. It's a very good procedure, but at present, what we were talking, some limitations are there. You can't correct hyperopia, customized treatment not possible at present, difficult in low power correction, you have to correct a lot of, take a table along that one. Bitoric, big astigmatism are difficult to treat with this one. Treatment is centered on the pupil, no cyclotorsion compensation. You can do it manually, but as such there is no cyclotorsion compensation. If you do a little decentration in the LASIK, it will not affect the refractive outcome. But for SMILE, it can cause higher coma. High coma, I think, is very, very common in SMILE patients and may persist up to 6 months in these patients. Then coming to my topic, that's advanced surface ablation. What are the indications over LASIK and SMILE? You can do it in irregular astigmatism, even in FFKC, if the cornea is thin, if there is a night vision concern like glare from large pupillar flap, there is an anterior stomal opacity you can correct along with your treatment. Then if the chances of contracted sports or hazardous duties, if there is a history of prior RK or AK, we are getting a good number of patients like that. And if you want to do wavefront treatment or customized treatment, and in the patient, if there is a RD surgery, filtering blab, deep set eyes with prominent orbital loop, we can't fix a ring on those patients. So it's very, very safe in those patients. And of course, you can combine it with C3R. The contraindications are just like any refractive surgery: herpes zoster, dry eye, glaucoma, irregular astigmatism, especially ectasia or KC, PMD, keratoglobus, uveitis, if there is a lenticular changes, and if there is a progressive retinal pathology like myopic degeneration, diabetic retinopathy, RP or RD is there. Then systemically, if there is a diabetes, don't do in pregnancy, lactation, rheumatoid arthritis or SLE. These are for general for all refractive surgery. Abnormal wound healing, keloids or Marfan syndrome, systemic infection is there, HIV or TB. If a patient is on drugs, you have to see that. If it is on antihypertensive, antipsychotic or antiparkinson's medicines, or these all causes dry eye and fluctuation of vision. Then as far as ESC is concerned, probably it is one of the safest procedure compared to all the corneal refractive surgery because we are creating a laminar cleavage. That's not in this procedure. And all the studies have demonstrated that the chances of getting ectasia is probably lowest in advanced surface ablation. The advantage of, again, not only ectasia, but you can even correct high number also. And the range, earlier we were doing it for LASIK rejects, and the range was around 3 to 4 diopters. But now the range is as good as of any LASIK or SMILE patient. So you can combine it with PRK. The goal of treatment using the topo-guided software is to normalize the corneal surface and improve best corrected visual acuity. I'll not go into detail, but say topo-guided treatment. So we just regularize the cornea. We don't take out the all refractive component, just try to regularize and use the minimum tissue. Coming to the techniques we were using earlier, this was very, very simple. Putting a local anesthetic drop, there is a removal of epithelium maybe by manual, maybe by AIOS, there may be laser can be used, or it can be alcohol assisted. This is, we remove the epithelium, laser is applied, and we use mitomycin, bandage contact lens. So it's very, very simple. There's no learning curve. Anybody can do on day one. Nothing is required. Only thing, he has to be good at refraction, what we were discussing. Dr. Monica has told you. Every refractive surgeon has to be very, very good at refraction. And he himself or herself should do it. Don't depend on your optometrist. And confirm and reconfirm in every visit. Antibiotic lubricating drops. So what were the complications which we were getting with the earlier systems? We were doing PRK, but there are some problems like stomal scoring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosions were there, and epitheliopathy. These are some of the complications which we were getting earlier. And we did so many things to improve our results. Like preoperative, careful preoperative checkup is a must. Look for the lid hygiene. Blepharitis, you do a good hygiene, scrub and antibiotics, manage it. If there is a dry eye, manage it first, then go for your treatment. Dry eye is very common in a middle-aged patient, and of course it's getting very common in youngers also. Then again in the operative procedure, we are using wood modulator. There is a mitomycin, which has changed the game, and it prevents the haze. Chilled BSS, proper fitting contact lens is again very important. Contact lens soaked on Acuvil or Acusat, what Dr. Rohit Shetty has propagated, is good for reduction of pain. Of course, I'm not using it now. Newer contact lenses are coming instead of bandage contact lens, which will dissolve itself. I think that will be a great thing. Then NSAID should not be used. Don't limit it if you are using limited 4 to 5 days. Then mitomycin. It's a potent antimicrobial which inhibits DNA, cellular RNA, and protein synthesis. It blocks keratocyte activation and proliferation, causes myofibroblast differentiation and subepithelial collagen formation. It results in preventing anterior epithelial stroma scoring. The drug is available in a vial. It's how you can dilute it and use it. Avoid any wrong mixing. You have to be very, very particular about that. And depending on the time, you can use for 12 seconds to 120 seconds, but I'm not using it for more than 60 seconds. And post-operatively, avoid overuse of topical anesthetic. In fact, I don't use at all. Oral prednisolone given for a day or two helps a little bit. Oral pain agents are now much better. And we have got gabapentin, pregabalin. You can use Ultrasat, or these are very, very good drugs and reduces the pain a lot. Then again, we have to improve the epithelial regeneration. We have to remember the hair, the healing is by epithelium. So the epithelial regeneration should be good. If you find any defect, use doxycycline 100 milligram BD for 7 to 10 days. Avoid UV exposure. I always give a good quality UV blocker goggles to them for my clinic only. I don't ask them to buy from the market because we are not very sure. Then nutrition supplements help in early recovery. This is the third thing which has changed a lot. That is the epithelial remover. That has come in a big way, which has changed the whole game. It's from Schwind. So what Schwind did, they just collected the data. They just collected the data and make a, it's like AI system. They made epithelial mapping and channelize his system, his pattern like whatever is common in most of the patients. So if you talk of central, it may be around 50, 40, 45 microns. There may be 10 to 15 micron extra on the peripheral side. So they try to mimic whatever the data is available with that. They created the pattern, which gave a very, very smooth surface. Then came the Streamlight from Alcon. It's again, I'm using this one. It's again very, very good machine. What they did is, it's a, what is the difference if you talk of the PTK and PR, present advanced surface ablation? In PTK, we were introducing around 0.75 or more of myopia. But at present, this PTK is neutral in advanced surface ablation. The surface is wavefront optimized profile. That means it's taking little more tissue on the sides as compared to center. So that causes very, very smooth surface. It mimics the human epithelium. And again, it's a one-step procedure. That means you are removing epithelium plus you're doing ablation in a single click. So this thing has changed a lot. Our range has gone up to 10 diopter. In LVP, they are doing up to 13 or 14 diopter. Of course, after 8 diopter, my first choice is ICL. But some of the patients who are not willing ICL or not fit for ICL, I go up to 10 diopter. You can correct hyperopia, hyperopic astigmatism, mixed astigmatism also with this one. Then it's a one-step procedure. There is a no time lag. And first epithelium is removed, followed by refractive correction done. Optical zone selection again is very important because you use the minimum optical zone required corresponding to refractive zone. That means the epithelium you are removing is the minimal compared to any other procedure using alcohol, manual or whatever you are using. Here the epithelial removal is minimal, rest of the epithelium is very healthy. That's why the recovery is very fast and quick. Less myopic shift compared to standard PTK mold. There is a uniform removal. There is no islands of epithelium as such. Epi-ablation zone automatically determined by the laser based on the PRK ablation profile. There is active eye tracking throughout the entire process. So just to summarize the advantage of transepithelial PRK at present, there is an accelerated healing and visual recovery by limiting minimum epithelium removal. There is a less pain in these patients, reduced risk of haze by accelerating healing, by smooth surface and better contour, by removing damaged cells, and by reducing thermal effect. The drawbacks or shortcomings, you can say, the flip side is that it accentuates the importance of epithelial mapping for the proper surgical planning. It causes more heat. It's still not available with premium profile like Custom Q or Contura. But even if you want to do it, you can do in a two-step procedure. That means you remove epithelium with this pattern, and then you can do Custom Q or Contura, whatever you want to do, or wavefront optimized treatment. And it has a price tag. So advanced surface ablation is a gentle, no touch, no cut, no incision. It's a safe, more biomechanical preservation of the corneal stability. It's a stress-free, faster treatment in a single step. There's no effect on the posterior segment. You're not putting any pressure. There are excellent clinical outcomes. Reduces dry eye by leaving nerves that can produce tear intact. Can be combined with CXL. Economical for you, easy to use, time-saving, low investment, no need of femtosecond laser or even microacutome for that matter. Just to conclude, these three things which has made the resurgence of surface ablation, there is a better XMR profile. We get a finer flying spot, mitomycin C, and better epithelial removal profile. That's a wavefront optimized one. Surface ablation is one of the most effective tools in the surgical armamentarium of refractive surgeon. It is still underutilized, but a very promising and exciting with superior results. Thank you. Thank you very much. Now we are
Dr. Vinod,
Yep.
we have heard you many times, and this is your pet favorite topic, but everything you add something new, that's wonderful. I have one question. You talked about Streamlight. I know only Streamlight because I am a Alcon user. Do you measure epithelium thickness in every case?
Ideally, it should be done because basically the epithelium thickness doesn't matter much. Only thing if there is an epithelium abnormality somewhere, then your result will be affected. Suppose your thickness is 50 microns and you put a 55 microns, it's not going to affect your refractive outcome. Suppose you put a 55, it's a 60 micron, it's not going to affect your refractive outcome. So it doesn't require that way, but if there is an epithelium abnormality, because here the healing is by epithelium. Unlike LASIK, SMILE or other procedure, the importance of epithelium healing is probably the most here. So if you can have, it's very, very good.
No, little exaggerating the question. If the epithelial map shows islands like 58, 60 microns thickness, but in Streamlight we can go only up to 50.
No, you can up to 55. You can do 55. I routinely do 55. You can do up to 60 also.
Really? I'll check.
Yeah, we can. I'm routinely doing 55 for most of the cases.
Okay. Thank
If the cornea is thin, then we reduce it again because the epithelium may be thin in those cases.
If the epithelium is thinner, you'll.
Cornea is thin, that epithelium
No,
layer
no,
will be
if
thin
the
also.
epithelial thickness is thinner,
Yes.
you will do a thinner ablation.
Pardon?
If the epithelial thickness is 45,
Basically, if you are correcting very low, say 0.5 or something, then it matters. But if you are correcting around 3 or 4 diopter, it doesn't matter. Your refractive outcome will not change even if you not put it properly. Of course, having measured it and doing it is a proper way to do it.
my question is little different, that you measure the epithelial thickness and accordingly feed to the laser to correct.
Yes.
Then do trans-PRK,
Yes.
trans-epithelial.
Yes, that's the way.
If it is beyond the range of what you can fix,
If there is any problem with the epithelium, I'm going to say
the laser machine
45 is normal, 55 is normal, 60, 65 is normal. If you're getting 85, that means something is wrong with the epithelium. You have to look at the patient again. So normal range is around 40 to 60 micron. So that's the normal range for epithelial growth.
that will you go with 50 microns in the machine?
No, you can do it to 40, 45. It has you can change the epithelium.
Streamlight gives, I'll check when I go.
In Alcon, it is there. You can just modify whatever you want to do.
You cannot modify beyond 50.
No.
Sir, initially I think it was 55 when I was using this machine and I had discussion with sir also. I had a patient 65 microns of thickness and that is what I discussed, and at that point of time it was not possible I think to change the exactly what you're saying. I think now I have...
Dr. Dhabi, what you are confusing with the PTK?
No.
In PTK, it restricts you.
No, I am talking only about Streamlight.
No, Streamlight, there is a quite good option. You can choose any thickness you
I'll
want.
have to check because they'll have to get it done
Yes,
in my
yes.
machine. Thank you.
For PTK, there is a limitation. You can do the limited ablation. If you go beyond that, it will stop. Suppose you are choosing a zone of around 8 micron. It will limit you around 40, 45 somewhere. If you are choosing a 7 micron, it will allow you up to 50 microns. That's inbuilt in Alcon as such.
I have experience with the Schwinn now, the latest one, and you can, this default is 50. In the center, periphery is slightly different. So
Yes.
it has about 5 to 10 micron difference. So 50
Yeah.
if it's center, 58, 55 or 60. The second part is you can modify with the epithelium ablation. Most of but the machine which you measure it, there would be a variation in terms of the epithelial thickness, because epithelial thickness, what we have found for the same patient, the variation is usually 5 to 10. Same machine,
Yes.
10 minutes apart, you will have variation
Yeah,
about.
see, I think it's not very, very reliable what you're seeing presently on the OCT. It depends on the optical surface at that time, maybe tear their time. So there may be some variables, but it hardly affects your refractive outcome. If the epithelium is healthy, doesn't matter much.
That's the only That's why I said whenever I hear Dr. Vinod, I carry on something new. That's
Please.
great, sir. And now, one thing more, that when do you
I'll
shift
come
to
back.
alcohol?
So sir has beautifully summed up all the technologies available, and only one point to be added in trans PRK. The best part of this machine is that the epithelial removal which it does is the margins are quite smooth because it is done with a laser. So the manual separation anyways we do with hockey stick or any other technology. The best removal of epithelium is with trans PRK, either Elcon or Schwint. But yes, the point sir highlighted, if possible, we should measure epithelial thickness in our patients. And if it is possible, as sir said, we should feed so that, we become more precise.
Yeah, my question is a bit similar only because I have EX500, but I have still not done a single streamlight on it because I do normal PRK. I use alcohol, remove the epithelium, and then do PRK. Because worrying about this situation, because even if in a normal, in a normal cornea, the epithelial thickness will not be uniform in all the nasal, and it will be more in the nasal and inferior than. So I was wondering whether we should have proper some maybe anterior OCT to find out the exact mapping and then go for it.
See,
or we,
just cut me short you. If you do with the OCT, you can adjust only the central thickness profile in your machine.
Okay.
You can't adjust 65 or 45 or
so
35.
you can't do that.
That's
Okay.
not possible in the machine.
Okay.
Secondly, what in Schwinn they did a study in a large human population
Okay.
and did the epithelial mapping. And based on that pattern, they created the smart surface pattern.
Okay.
In Elcon, they did a similar thing, but it make a wave, this called wavefront optimized. That means we know the center thickness is around 50. In the periphery, I might say around 7 millimeter, it will be around 65.
Yeah.
So just like they've created the profile, what is very common in the most of the humans. So you can't change it based on the OCT except the central thickness.
Okay.
Yeah. So, but I'll just tell you, if you use this thing, this is a very good, much superior what you're doing alcohol.
Yeah.
There's no collateral damage to the surrounding tissue. That's number one.
Yeah.
Whatever the precaution you took, some alcohol may sweep there.
It always.
Even the minuscule of very, very microns or something, it will spill there. So that will damage your cells.
Yeah, exactly.
So it keeps the collateral cells very, very healthy. That's why you will find the much better recovery.
So previously I was doing first PTK and then I was doing laser. For these patients, I was doing using the PTK mode and then I was doing the excimer laser. So is that also okay if I do with that?
Only thing, it introduces a little bit of myopia. You have to just adjust in your nomograms.
Okay.
Second, the removal is not uniform that I was telling you. It will remove the epithelium 50 micron all over.
Oh, all over, right.
Yes.
So
It will-
streamlight is much better than.
Streamline is much better that way. Even if you are using alcohol, I'll say don't do with the laser.
Yeah.
They will get a very smooth surface and your surrounding structure will be saved. Even if you're not doing this streamlight.
Okay.
Even with alcohol, you can do that also.
Pardon? Not streamlight means?
Don't use alcohol.
Okay.
And if you're not using steam light, you just do the laser scraping of the epithelium, remove by laser. Like a PTK mode even does.
Acha, even that will be better than the.
That's give you better results. Your recovery will be very smooth.
Yeah, I know. Thank you, sir. Thank you.
So, any questions to panelists?
I think time is.
I think so. With this, we wind up our session. Thank you very much, and thank you for the audience. We are more on the table now, yes, but thank you for a dedicated audience also. Thank you so much. We have a group photograph, then we'll disperse. You can join us also.